Hello, everyone, and welcome back to Rarely Typical, a podcast where I am talking about living life with a chronic illness, finding hope, and living a life that's rarely typical. My name is Sherry Langan, and if you are new here, I'm the host of this podcast, and I was diagnosed with pulmonary arterial hypertension in September of 2018. I am 7 years post-diagnosis, which is super exciting. And at the time of my diagnosis, I was still figuring out all of the things that came with this diagnosis. But when I was diagnosed, I was actually diagnosed twice, which is a part of my story that I don't talk about a lot. And so today we are going to be talking to Dr. Peter Hountras, who was my second diagnosing doctor. I always say you're my diagnosing doctor, but you weren't really like my actual diagnosing doctor. And then we have a special guest today, Dr. Hountras' wife, Stacy Hountras, who is a nurse practitioner at a local clinic where they live in Denver. So we are talking about the whole picture today. We are going to start with what it looks like when you are initially feeling symptoms, when you go to a doctor that is not a specialist. And then we're going to talk about how you end up with a specialist, because I feel like that is a question that I get the most is I'm having symptoms. I'm having all of these things that I know something is wrong. How did you get diagnosed? How did you get referred to a specialist? And so today I have both sides of the story, and I think it'll be a really good podcast. So, hey guys.
Hello.
Hi. Thanks for having us. And I'm still claiming to be your diagnosing doctor. That's mine.
It's definitely less of a mouthful than saying you were my second diagnosing doctor.
That's right.
Yeah. I'm Stacy, and I'm a family medicine nurse practitioner. I work at a local community clinic in Denver, Colorado. Our clinic is a federally qualified health center lookalike. So that means that we see just about everybody, and we're considered like a safety net.
Hey guys, great to be back. My name is Peter Hountras. I am a pulmonary critical care physician specializing in pulmonary vascular disease and pulmonary hypertension here in Colorado.
Awesome. I'm glad you guys are here today. We're going to start at the beginning, and we're going to start with Stacy, because Stacy is the first person, I guess, in the line of medical professionals that you would run into if you were having the situation in real life. So when I was diagnosed, I was having a lot of symptoms. I was really tired and I was gaining weight and I was retaining a lot of fluid and I was having a really hard time breathing. There were a lot of things that were easily explainable when you isolate each symptom. And so it actually took me a while to decide that something was wrong. The weight gain is what pushed me over the edge and pushed me to go to the ER. But all of the other symptoms actually made sense to me. The only reason I was actually seeing anybody was because something about the state of Colorado does not bode well with my allergies. And so I was having this like really weird like sinus stuff. And so I was going to urgent care. And that was like my misdiagnosis era, I guess. I was seeing an urgent care doctor and I went in probably 3 or 4 times in a span of a few months. And they were taking me at my word, right? I was saying, I'm having all these sinus infections. I'm having all these sinus problems. I feel like I'm having allergies. And so they just took what I said, which was what I felt like was an issue, and they treated what I was saying. But I didn't realize until hindsight that there were so many things that were adding to this. It wasn't just what I was going in for. And so how, Stacy, do you decide that something is wrong? I mean, especially when the patient doesn't even realize that something's wrong.
Yeah. I guess part of our training is looking for red flags. So, as an example, chest pain with exercise would be a red flag, or, a breast lump that really looks very unusual. I would not hesitate to refer that out. That being said, primary care can do a lot of different things, and it is a good idea to start at a primary care in general if you can, if that's an option. It's also more efficient for you if you can continue care under like one person instead of kind of hopping around. And it's also safer.
I think that relationship was key. And a good primary care doctor is able to kind of see past a lot of those acute, urgent things and be able to try and piece things together. And so, as Stacy was saying, having that relationship and thinking about it from a bigger picture than just taking advantage of somebody who's there in the moment dealing with something that they're seeing just in front of their face and don't have as much context with if you were to go someplace like an urgent care or the emergency department.
Do you think that, I mean, I know patients go to urgent care to start with, right? Like when they're going to urgent care multiple times, do you feel like an urgent care doctor would probably say, oh, you've been here like 4 times in the last 3 months. Probably should go see somebody else.
One would hope.
To a specialist. Yes.
Yeah.
It's
Yeah.
not exactly referring to a specialist, but do you think that an urgent care doctor should have told me at that point, like, you should go see your primary care instead of continuing to come to urgent care?
Well, after like 3 or 4 times, yeah, for sure. I would also hope that if there were, I wasn't there. So, but I mean, if there was, you mentioned all the swelling and the weight gain, if there was fluid on your lungs, I would be very quick to refer you and say, you should not keep coming to urgent care. You need continuity.
That's fair. Eventually, I did go see my primary care, and I was very thankful that she did take it seriously because by that point, we were pretty far along in this crazy up and down. She definitely noticed the swelling and she tested for blood work, but it wasn't a clinic that had blood work in-house. And so she had to send the blood work out. And before the blood work came back in 48 hours, I had already ended up in the ER. What prompts you to refer to a specialist?
Sometimes it's after a decent workup, ruling out the most likely candidates. Sometimes after a 2 or 3 month trial of a treatment, then I would refer to a specialist for the next steps. I mean, they're an expert. They have expert training for that. I'll also share, though, it depends on your primary care's background. Like my work bestie, before she became a nurse practitioner, she was a nurse in neuro ICU. So she would feel a heck of a lot more comfortable spending a longer amount of time in that process with some neurological thing. And I would probably trust her judgment more than me, who did not do neuro ICU. I'd say in general, it could be when there's an unclear diagnosis, or, for example, somebody with a heart arrhythmia, and I don't do ablations. I shouldn't do ablations. And so I have to refer to a cardiologist. It could also just be something is not right. This is not how it should be. This is not going as it should. I don't like how this looks. This looks bad. And at the very least, I want somebody to hold both of our hands and say it's not bad.
We love a self-aware nurse practitioner. So like somebody comes in and they're having all these symptoms, but obviously there aren't tests for every symptom, right? And
Yeah.
how do you decide what testing to do? Like what is the most important at that moment? And then what happens if that result comes back normal?
Sure. Honestly, the first thing that came to mind with prioritizing was like my time in the hospital. So how's your airway? Is this heart related? Is this very dangerous for you? Yeah, seizures, fall down the stairs, things that are high risk. So there's a lower threshold to respond. There's a lower threshold to send that out for sure when it's higher risk. When a test comes back normal, it is still a test result. It's helpful. So, hey, we did a skin biopsy on this funky looking mole. We definitely sent the mole, and we're going to trust the pathology that it's a seborrheic whatever. So it's reassuring. We accepted it as it's still good data. It's helpful.
I think that's important for people to hear because I
Yeah.
feel like normal test results get such a negative connotation when you're talking in the chronic disease space. People are always like, oh, I only had normal test results. But I like what you said. Obviously, it is a good result and we don't always get good results. So I would be happy with a normal result. I would also just be frustrated if I knew something was wrong and it was still coming back normal.
Sure. And not all the tests can diagnose the same thing. Like giving the example of a cough, The chest x-ray might be normal, and that's just like a two-dimensional picture, whereas a pulmonary function test is telling us, well, how well are the lungs functioning? That's different. That can diagnose some different things.
That's true. When I was diagnosed, my heart failure blood work obviously was through the roof, but that heart failure blood work did not tell us that there was pulmonary hypertension. So I can understand that.
Yes, exactly. And then there's some tests that are just really inspecific, like some inflammatory tests. Like, well, you were just getting over a cold virus, so maybe that's why some of your inflammatory markers were just a little bit high because you're dealing with something. But that doesn't mean you have lupus, for example. Well, we have to put things in the whole picture. I wish that there was a perfect test for each individual thing, but a lot of times it takes interpretation of the big picture, including the physical exam. I mean, you can never forget, like, well, what does the person look like right in front of you? Do you need to question a test result? Because the test result would suggest they're dead, and they are not. So maybe I should repeat that test, right?
And sometimes when you get those negative test results and the patient is still having symptoms, that potentially could be a trigger, right, for a primary care doctor to refer to somebody else as well.
Excellent point. I should have said that. You're right.
So when I was diagnosed, I was actually pre-diagnosed in the hospital. So I was prompted because we were not testing for anything, but she did blood work. And because those results didn't come back immediately, I ended up in the ER because of the flu. And when I got there, obviously they admitted me right away after seeing my ECG and started doing all of the tests. And like Stacy said a second ago, we were eliminating things that it could have been that was causing the heart failure. And eventually we got to the pulmonary hypertension diagnosis, but there was not a specialist in the hospital. And so we did all these tests and they said, there's a cardiologist here who knows of it, but there's actually a center in Denver that you can go to where there are specialists for this. And so I was referred by way of the ER, not by way of my primary care. And so once I got there, we had to do all of those tests that I had just done again. And then I also had to be readmitted to have all of those redone. So what happens, specialists, what happens when we are referred and then like, what is the next step, I guess, once somebody is referred?
Yeah, that's a great question. So I think the best thing is when you have somebody as a strong primary care doctor or a strong ER doctor that they start the process off and lay the foundation and give a little bit of a direction and guidance as to what they think is going on, and that it's our job to try and pick up those hints, those pieces, those clues, and try and finish off the puzzle to be able to definitively say yes, no, or otherwise. And with that, we obviously as specialists take the opportunity to review all the notes, all the imaging, all the labs, all of those things that, you know, primary care people like my wife spent so much time doing and talking with and trying to get all that information, because that allows us to start at a more advanced point than just having to start over. Obviously, the patient's perspective and wanting to fill in any sort of gaps and timelines are important, but that at least gives me as the specialist walking into the room at least a little bit of a understanding of where I think I might be going with this conversation and what's going on. As far as specific testing, when you're dealing with things like rare diseases, and this is not necessarily for every rare disease, we need to make sure that testing is not only done the right way, but make sure that we have all of the specific angles and images, all the specific nuances and things, because it potentially can make a difference as far as what we think an underlying cause is, what a treatment might be. And so because of that, it may seem cumbersome to say that we want to try and do these things again, but we don't take the idea of giving somebody a rare disease diagnosis like pulmonary arterial hypertension lightly, because that is very impactful, as you've heard Jerry talk about in so many other podcasts. And so we want to make sure that we've got the right information for the right diagnosis to lead to the right treatment. And so sometimes that means having to repeat things and making sure that we have all of the necessary aspects to go into where are we now and where are we going.
So do you guys always repeat tests? Like new patients, you always repeat tests?
Not always. Part of it depends on where they're coming from and do we actually have access to the images versus just the reports. And then the other part of it has to do with what exactly are we trying to find and what do we need done, right? So, for example, a right heart cath is almost always going to get repeated at our institution. One, because we want to make sure that the numbers that we're seeing that were given to us were absolutely correct, because we usually can't see the waveforms that they obtain to do a verification. But two, we do extra things like we'll do the vasodilator challenge with inhaled nitric oxide, or maybe we're worried about chronic clots and we need to do an arteriogram, right? Those things probably were not done at the outside hospital. And so, again, wanting to make sure that we have those right things. If there are things like pulmonary function tests or a chest x-ray or a CT scan that are a little bit more standard, usually those things we don't have to repeat unless there's a reason. We're following up on a size of a nodule. There's something that needs to be repeated on in the near future. But the big things for us within rare disease, usually we want to make sure that we have good quality control over what information we have and why we're doing that.
Sometimes the specialists repeat tests because they're looking for trends. They want to know if something is changing. And, for example, with kidneys, they really need to know the numbers right now before they prescribe you something.
And so those tests, like those very specific tests, obviously, are only done and only ordered by a specialist, correct? Like, Stacey, you cannot order those tests.
Right. Yeah.
I mean, she could.
Well, technically, I guess I could. It's within my license, but should
sure.
I? I should
That's
not.
more the question, and just making sure that she orders the right things. And even when we're dealing with a pulmonologist or a cardiologist that lives more in this realm, but maybe not see as much as I do, they will have conversations with us as far as like, oh, somebody's coming from out of state or far away. What would you like done here versus what are you guys want to do in Colorado or in Denver at the specialty hospital, so to speak? And so there is some of that conversation, and I think we've done a really good job of trying to balance out what can be done ahead of time versus what should we do when they're here, not try and delay time to the appropriate diagnosis and treatment. And so we try and have that back and forth as much as possible. I think the more that you share patients, the more relationship you have and trust there is, as we've talked about on other podcasts, that ability to be able to have those conversations and have people feel comfortable in reaching out about what do you want me to order? What are you guys going to order? And how can we do this in a timely manner? Works more efficiently. But if it's first time somebody's sending somebody over, those types of things, that might seem a little bit more like we just took stuff and threw it against the wall and whatever stuck was there.
I feel like whenever you go see a new doctor, you go to a new facility, I feel like everything is always so clunky. And anytime I've ever had to switch facilities, which has been a lot at this point, I feel like the transition is so clunky because having to ask for medical records, and then also now you have my medical records, but that wasn't good enough and we have to repeat those tests, which is so annoying as a patient because I just had this test done 2 weeks ago and now you want me to have them redone, especially when they're invasive tests like a right heart cath. But when I was in Colorado, the primary care doctor that I was seeing is actually part of the UC Health umbrella. And so after my diagnosis, I don't know if she got the report or if she was just like thinking about me and she like checked my chart, but she was able to see my diagnosis and all of the workup that I had in Denver. And she called me herself and she was like, oh my gosh, I saw your report and I saw your diagnosis. I'm so glad that you got, diagnosed. She said something like, yeah, the blood work was obviously insane when we got it back, but by then you had already been admitted to the hospital. So it was nice to see follow-up. Stacey, when you refer out to a specialist, do you have follow-up with them after they leave, or do they come back to you at some point? Because I didn't go back, so I don't know.
Yeah, it kind of depends. So part of my role is like general health maintenance and preventive services. So while I'm not going to be touching your pH meds for dang sure, or without very specific permission, well-documented permission, I still would service that person for your preventive health services. So making sure your PAP is up to date. If your pulmonary clinic doesn't already have you fully vaccinated against all the respiratory things, then we wish you to do that. Or frankly, what if you stub your toe and you think it's broken? Come on in, but not going to mess with your pH. I'll certainly keep your medication list updated and I'll read the notes, the consult notes as they come in. You mentioned that primary care person was reviewing or somehow already knew that you were admitted before you came in. She already knew that you were admitted. Probably she got an admission notification. I
That's
just
one of
had
the
that last week with a patient who I just immediately called and, like, how are you doing? Are you okay? I am so sorry this happened. That's wow. Wow.
Is that an
it
automatic kickback?
It depends on if you're within the same health system or not. So if you're within the same health system, usually you get an automatic kickback if somebody gets admitted. What should happen, regardless if you're in the same health system or not, the specialist should be sending to, for sure, the referring physician, but hopefully also their primary care doctor, if you have access to that, some notification that you've been seen by the specialist and some update as to what's going on. And you have a little bit of control depending on what your electronic medical record is as to what that information looks like. Personally, I try and just send the most recent updated note, just because, again, there are people that want to really dig into the weeds that are primary care doctors and kind of go through my thought process and see what's happening.
Mhm.
And some other people just might want to jump to the cliff notes and go, okay, what's happening with their meds? How do you think that they're doing? When are you going to see them back? But I think Stacey's 100% right. You should not leave off your primary care doctor. They are extremely valuable. So often people want us as the specialist to assume that role as a primary care doctor. And I think that's very flattering, but there are good reasons as to why I went into being a specialist and why my wife is doing primary care, as well as our clinic is not equipped to be able to do all the things that Stacey's is. And so there are specific things that need to still be done within the realm of a primary care office. And it's important to us still have that communication, but to also kind of know the lanes and be like, okay, I get that you haven't been to your primary care doctor in 12 months and you're out of all of your other medicines, but that is really the person that needs to be, managing your high blood pressure, your diabetes, and your thyroid. That should not be me.
Something that came to mind, Peter, was, for example, when people are diagnosed with a really serious condition or certain things are just terrifying, like if you cannot breathe, it is terrifying. And so if you didn't already have anxiety and insomnia, you sure as heck do now. And so getting mental health services through your primary care, and that might look like a combination of psychotherapy, cognitive behavioral therapy with a therapist, plus maybe being prescribed a daily SSRI to help you stop obsessing or having panic attacks, which are affecting your life function. So that's where the primary care is kind of an adjunct to what's going on, because the issue is secondary to what the expert is treating. And I don't know, Peter, do you ever prescribe to SSRIs and stuff like that? I don't know.
I mean, we may, if they're inpatient with us and we're dealing with some of those things, and potentially start them on that as far as discharge. But the hope is still to have either mental health or somebody like their primary care doctor kind of follow up on that. Obviously, again, just like you said, with primary care and having people that have more comfortable doing things, there are specialists that have more comfortable doing things as far as how far they kind of extend their reach. But you just have to be very careful, because the last thing you need is to have multiple cooks in the kitchen and multiple people managing the same drugs. Because
Yes.
it turns into what we call polypharmacy, or a situation where there's lots of different meds on the list. You don't really know what doses somebody's on or what they're taking, and that can be very dangerous. And so as hard as it can sound sometimes to patients and wanting just to have one doctor control everything, there really is a reason and a rhyme to it. And again, it takes coordination, as we've talked about before on other episodes, but it's very important.
When it comes to you're taking a special medicine from a specialist, like some of Peter, your medicines cause a lot of itching. Well, primary care can handle itching, but this is a side effect of a medication you are taking for your, special condition. And they are best equipped to know what to do. And they should probably know, because let's say it's not itching, but it's actually continuous diarrhea. I don't know. That's the thing. But they really should know, because they might need to taper your medicine or just switch. Certainly, if there's some side effect after a procedure or a surgery, well, you really should notify the person who did, or the team who did the procedure and the surgery.
Either way, I do not see primary care. I let Moss handle all of my stuff. I do see other specialists. Obviously, I see an allergist and a dermatologist for my skin and all of those things. And retina, now that I've had a retina tear and I see an eye doctor. I see lots of other doctors. I just don't see my primary care. I have established with a primary care because I do understand that that's important, but I actually don't see him. And I cannot remember the last time I did see him because honestly, Moss does prescribe most of my things that I need. And that's probably not good advice. So if you guys are listening, just don't take that. But that is my reality here.
But it speaks to, that it can be individualized. It depends on the provider.
Yes, it also depends on whether or not you have a good primary care. And I do feel like we are in what everybody calls like a medical dead zone. There's not a lot of good primary care here or like care in general here. And so most people travel to Orlando, and I'm already traveling up to Mayo Clinic. So like, I don't want to also have to travel to Orlando just to see a primary care. I have been at Mayo and needed to see an allergist or needed to see dermatology. And Moss has actually referred me to Mayo dermatology and Mayo allergists. And so that helps because there's a big network there and they're able to do that. So I know that that's not everybody's reality, but that's where I'm at.
Yeah.
Okay. Well, I do think that all of that was helpful. I think that covering stuff like normal test results, covering stuff like why we have to redo tests, those are some of the big questions that I get. And some of the things that I see patients get hung up on is like, my tests are normal, my doctor's not ordering any more tests, or I have been diagnosed and now this diagnosing doctor wants to rerun all of these tests. And so I feel like this was a helpful podcast episode. I also think that it's really helpful to have both sides of that in this podcast episode, is like having both a primary care and a specialist be able to give you their opinions on it. So thanks for joining me today, guys.
Our pleasure.
Thank you for listening. If you got something out of this episode, please like or subscribe, and I will be back next time with another episode. Bye, guys.